All right.
So I will let you know that Stephen Thielke is a geriatric psychiatrist and health services researcher at the University of Washington, and also at the Puget Sound VA Geriatric Research, Education, and Clinical Center, affectionately known as the GWEC. He is the GWEC Associate Director for Education and Evaluation, and he conducts research about dementia, medications, depression, and pain in older adults, and the use of monitoring technologies in healthcare. And today he's going to give sort of the foundational lecture for this term series on the whole person in dementia. Welcome, Stephen.
Hey, thanks, Barb. Thrilled to be here, as always. Barb and Michael certainly showed great foresight in making sure that these lectures were available via technology. I don't know if they predicted the pandemic, but they sure were ready for it. So it's really cool to be part of this series and to be here, even if we can't have in-person meetings. I think this series that Barb and Michael have put together is a wonderful foundation for understanding dementia and dementia care, and I know that you will enjoy all of the talks. So I'm honored to give the first one, which really I have one purpose, and that is to encourage you to not medicalize dementia, to think about the person's role. Barb started with this with the 4 M's. The 4 M's are really about person-centered care and making sure that you understand the dimensions that go into the older adult's life experience. And as we see people who have dementia, we need to remember that. It's not a problem with their brain. It's not just a disease. It's something that affects their interaction in the world. And that's what I'm going to try to underline, even as we go through a lot of the nitty-gritty of what dementia is. If you're looking for more resources, this is a very nice set of modules. You can check it out for yourself. You can see what all the specific details are. And this is part of the HRSA, the HRSA project that ultimately supports the Northwest Geriatrics Education Center as well. So as Barb mentioned, I'm happy to, to take questions during the talk. If you have questions, so there's chat and there's Q&A, just type them. I'm not seeing chat. Oh, here we go. I'll bring chat up and I'll keep that in the corner. And if I'm not making sense, if I get garbled, if you think I am feeding you a load of untruths, just please type it, and it's better to address it than to wait at the end. So this slide, it tries to show you what's really at stake in thinking about dementia and what I meant about not medicalizing the problem. All of the things on the bottom are the basis of clinical medical knowledge. You start with a definition of what the disease is, talk about the rule outs, causation, differential diagnosis, variations, and so on. And so if you did this with diabetes, you'd start with insulin and blood sugar and the pancreas and type 1 and type 2 and what blood sugar levels mean and how often it happens in what populations and the natural history. And that gives you a sense of a disease, a medical problem. But it doesn't tell you what the experience of the disease is like. And it doesn't tell you what the right thing to do is. And in my experience, the problem with dementia is that if all you understand is the factual basis of the disease, the science behind it, you will completely miss out on the human angle, and you'll be focusing only on the brain and what's broken there, and not see how the person and their environment is impacted. What I really believe is that you don't need the science to understand why dementia is a problem. And you don't need the science to tell you the right thing to do in dementia care. If you believed that dementia was caused by evil pixies who came to somebody's head in their sleep and cursed them, and that caused them to lose their memory and thinking, but you had an understanding of what the person's experience was like, you would probably do a better job of helping them than you would if you were a Nobel Prize winner in the brain chemistry of dementia. So I'm going to be talking a lot about the chemistry and the science of dementia, but I really want you to remember, first and foremost, that doing the right thing in dementia care involves thinking of the person and understanding what they're facing, and not so much the scientific basis of the disease process. All right, so to bring this home, I wanted to run through 3 scenarios real quick, and I want you to give these honest consideration. So think about if you yourself were in this setting. So let's say one of your parents starts to have memory problems, can't remember their pills, they get lost, they're paranoid a little bit, and they're leaving the stove on. What would you do in this situation? So think about, you get a call about one of your parents, hearing this news. How would you deal with it? And what would your needs be to address this problem? And what would you expect from medical care in dealing with this? Like, would you think, oh, I'll take my parent to the doctor and they will get fixed and there won't be any more problems? Or would you expect that they would tell you something that you would have to live with, but there's no cure for it? I've asked this question, when we had the luxury of in-person lectures, and get a lot of varied responses, as you might expect. Some people would say, oh, I'd quit my job, I would move home and take care of my parent. Other people would say, well, I'd find somebody else who would help figure this out. There's clearly no right answer, but what I want you to see is that this degree of problem would force you to make a lot of decisions, in addition to your parent and the people around your parent. Now let's say it's even more severe and your parent requires help with activities of daily living, and also they don't remember who you are. And let's just hypothesize that you're the only person available to care for them. Everybody else is too busy. What would you do here? Would you quit your job to take care of them? Would you tell them they're on their own and they can spend their savings to hire care? Would you find them another place to live? There's a lot of practical problems that you would face, and your needs, I'm guessing, would all revolve around somebody to take care of your parent in this situation, whether it be you, or whether it be a paid caregiver or some type of living facility. And I think when you appreciate the problems in this scenario, you'd also know that medical care is probably not going to fix this. Like, what you need is social work support, or caregiving, and or money to pay for stuff, or long-term care insurance, something like that. But it's not a medical problem by any means. And I don't think anybody would expect that in this situation, you're going to get a medical cure. The third situation is a bit of a frame shift, but let's say you live in a different culture or society where there's multi-generational housing. People are always at home. They don't leave the house to go to work. There's a lot of flexibility, and there's a lot of people around. And let's say you have an older adult who has the same level of in-person needs. So just think about how things would be different in this setting than in the setting where you're the only child who is available to care for your parents. What you appreciate here is that you still have some problems, but they're much less because you're part of a mesh, a connected social structure that can look out for your parent without having to either change everyone's life or to purchase care. You'd still have the same sort of needs, but there are a lot more people to address them. And once again, medical issues really aren't at the forefront. So when you think about dementia from a broad, like worldwide perspective, what you realize is that it's a first world problem where we live in fragmented, smaller nuclear family units, and parents are expected to take care of themselves when they get older, and children go off on their own. So the reason we're talking about this as a big deal has more to do with social structure than it does to do with medical problems. And in fact, in many parts of the world, at least in times past when there were more cohesive social structures, people didn't even really talk about a thing of dementia. It was just expected that as people get older, they will have more needs. They'll become senile or not be able to do things, and other people will look out for them. And that's just, expected. So it's a problem for us because the way our lives are structured, we're not there to look out for older adults. So I hope you can give that one some thought. It took me quite a while to realize that dementia really is a problem from a socio-cultural perspective rather than a medical perspective. But I think that really does explain the challenge that we face now. All right, so let's jump into this. And I don't want to belabor all of the medical part too much, but I think it's important to get a clear sense of what dementia is and is not. So I'm going to go through 3 definitions of dementia, each of which is a slightly different lens. The first one is just a listing of the characteristics. So it's a significant problem. It's chronic. It's not something that happens quickly. It's a loss. It's not a constant deficit. And it involves memory and or mental functions. It's not just memory. And there are structural changes in the brain. It's not just neurotransmitters or somebody having a bad brain day. There's actual brain changes involving cell death. The second definition is a little bit more specific. That is, it's a progressive neurodegenerative condition with functional consequences. And each one of these is important more for what it says dementia is not rather than what it is. So it's progressive. It's not just fixed and stable. So it's not lifelong. And it's not acute or abrupt. It goes slowly. It's neurodegenerative, which means that brain cells are dying. It's not just a normal malfunction. And it has functional consequences, which means that it impacts the individual's ability to do things. It's not just that somebody feels like their memory's not working or they show some problem on tests. In fact, it involves their incapacity to carry out activities. You'll see that it's not necessarily some of these other challenges. It's not just memory. It's not necessarily Alzheimer's. You don't have to have behavioral problems. It could happen at any age, although it certainly usually happens older, and it's not necessarily a fatal problem. Instead, it's a slow, steady decline in the ability to do things that is explained by neuron death. The third definition is the technical one from DSM-5. Real quickly, it's a decline in functional domains. There have to be functional problems attached to dementia. That's critical. If you're going to remember one thing about what dementia is, it really is this part of functioning. Unless you have functional changes, you do not have dementia. Dementias, the symptoms of this aren't due to a medical problem or delirium. And then it lists there what the different domains of cognition are. In DSM-5, it's categorized as being possible or probable. Then you say whether there's behavioral disturbance or not. And importantly, the degree of dementia that you have is based not on your test scores, not on how you do on some cognitive test or on a lab value or imaging test. It's on your functional status. So at a mild stage, you may have some troubles with more complicated activities of living. At a moderate stage, it's more of the things that everyone can do. And then at a severe stage, you need more help. So once again, the diagnosis of dementia depends on functional status, and the severity of dementia depends on the degree of functional impairment. So there's a question there about tests for dementia. That's a great question, and we'll get to that. And basically, there's no one test for dementia. It's based on a clinical history and ruling out other factors. But it's not like we have a dementia-ometer that will tell you whether somebody does or doesn't have dementia. That's a really good question, and we'll get to it. So the challenge along those lines is that there are other conditions that overlap a lot. So delirium and depression can, like dementia, show confusion, trouble carrying out things. People don't quite seem right when you talk to them. And there may be concerns about the individual. But delirium happens quickly. It's a medical problem. I hope you get more attention to delirium in this and other courses because it's important to recognize that basically it's a medical emergency that causes cognitive difficulties. So if somebody was okay 3 weeks ago, oh yeah, Emily's there. She's going to be talking about this a lot more next week. I forgot that the schedule is there. Thanks, Emily. And so she's going to be reviewing this much more. I'll just give a quick synopsis. In delirium, it happens quickly. There's much more waxing and waning day to day. And the main problems are around confusion and attention. With dementia, as we'll review, there are specific types of difficulties that people have around those cognitive domains. It's slow and steady, and it involves functional changes. And then with depression, the main finding is typically around impaired concentration or interests. So when you test somebody, they usually do relatively well, although they may have problems. But their family or loved ones might get the perception that they are cognitively impaired. So as Emily mentioned, you will get much more useful detail about this next week. So dementia, as I mentioned earlier, is strongly age related. That is the single biggest risk factor for dementia. So about 1% of people at age 65 have dementia, about 6 to 8% for everybody after 65. And then once you get in more advanced ages, it really is much more common. So you can expect that the rates go up. This is a study of 6 different areas around the world, or 5 areas. One of them is the same set of data. But basically what it shows is that as you get older, the likelihood of dementia goes up and up. And it's not just a straight line, it's more of an exponential curve, and there's an actual equation that describes this. So what you can see is at age 65, the likelihood is extremely low. At age 90, it's quite common. So what I want to quickly go over the main subtypes of dementia. This lists some of them that we won't talk about in much detail. And the key to this figure is to notice that there's considerable overlap between the types. So it's not separate boxes or circles for all the different types of dementia. Instead, they frequently occur together. There are some studies where the co-occurrence of Alzheimer's and vascular disease, which would kind of be the overlap between those, is even more common than pure Alzheimer's disease, which would be the one without anything else. Lewy body very often occurs more commonly with Alzheimer's than on its own. So don't read these mathematically, but clearly there is a lot of overlap. And what I encourage you to recognize is that they may not occur as pure conditions, and that you want to make sure you have an open mind as you're thinking about the type. This is just a very quick review of the parts of the brain. Certainly oversimplified, but it breaks it into 5 parts here. The frontal lobe, the yellow, the occipital lobe in the blue. So the frontal lobe is all the kind of executive functions that we have. The blue one is vision, and the pink lobe on top is parietal cortex, which is what's known as association cortex, and then the purple one is the temporal lobe, which involves a variety of functions, including having the hippocampus in the medial temporal lobe, which is a major player in memory. So this is very oversimplified, but dementia is mainly considered to be a parietal temporal problem. So the pink and the purple areas are the ones that have the most problems. And in particular, the inner part of the purple lobe, which is where the hippocampus is. And then the one on the bottom underneath there is the cerebellum, which is responsible for coordination, basically, or smooth movements. And that one has not received a lot of attention in dementia, but it probably has a bigger role than we expect. So don't assume that dementia is just one part or the other, because it really is more of a global figure, or a global deficit. So I'm going to go through these 5 types of dementia to give you a brief overview, and then we'll circle back to more of the context and the epidemiology. So there are Alzheimer's disease, vascular disease, Lewy body dementia, frontotemporal, and then what we'd consider to be reversible dementias. And please remember that there is considerable overlap in all of these. So Alzheimer's disease is a fascinating story. If you wanted to know more about it, I would just encourage you to read about Alois Alzheimer, who did most of his work in the early 1900s. That's him on the left. On the top right is the first patient whom he diagnosed with this unusual condition, whose name was Auguste Dater. She was youngish at the time, even though she looks quite old there. She had a lot of hallucinations and paranoia. In particular, she believed that she was being persecuted and that people were unfaithful to her. She showed significant memory and other cognitive problems, but at the time, nobody had identified what was really going on. The asylums at that time were mainly filled with a condition known as paralytic dementia, which involved other symptoms. And one key finding in that was that the people had certain inclusions in their blood that involved neurosyphilis. So the main cause of dementia during those days was neurosyphilis. And Auguste showed different symptoms from that. And Alzheimer really was brilliant for picking up the fact that she presented differently. And so he became interested in what may have been going on. And he conducted a autopsy and looked at slices of her brain and drew these pictures. These are actually what Alzheimer drew from her brain. And he noticed that there were two abnormal findings, which we now know as plaques and tangles. They're the hallmark findings in Alzheimer's. The amyloid plaques are there, they're outside the cell, and they're made of a misfolded form of amyloid protein. And then the neurofibrillary tangles are inside the cell, and they are made of another protein called tau. Both amyloid and tau occur everywhere in your body, in and around all your cells. But when they occur in the wrong form, they glom together, and then you get these plaques and tangles. You might ask, well, are the plaques and tangles the cause of Alzheimer's? And there's a lot of research that kind of suggests as much, but I don't think that's really a fair perspective. Instead, I would say that the plaques and tangles are something that happens when you have Alzheimer's, and in particular when your nerve cells die and when the environment for the cells starts to go astray. So unfortunately, it's not like there's a single chemical or something that is in the body, and if we could just get rid of that chemical, suddenly the Alzheimer's would disappear. In fact, what you have going on, as you can see in this figure, is that you start with the misfolding of the protein and end up with a cell death. This figure makes it look like we understand exactly what happens with the plaques and tangles. Unfortunately, we really don't know that much. And in 100 years, there's been a heck of a lot of research, but we're still not very close to understanding exactly what starts the process, what continues it, or how we could possibly prevent it. So there's a question there about the only way to have a positive diagnosis through autopsy. So great question. Formally, in order to be 100% certain, you definitely would want to have an autopsy to confirm this. Group Health did an interesting study where they looked at the brains of people who had been diagnosed during their lives and found that quite a few of them who had like classic Alzheimer's symptoms, everybody thought it was Alzheimer's, didn't have plaques or tangles. So then you say, well, what's going on? However, the clinical diagnosis based on the findings really is quite good. So we make a diagnosis of dementia with some confidence, even if there is no actual formal confirmation by brain tissue. And obviously, doing like a brain biopsy to get tissue isn't a good idea. There are other tests being developed. I'll talk about some of the shortcomings of those that try to infer from imaging findings or lab values whether or not you have Alzheimer's. But what I want to suggest in a bigger picture is, given what we know about the condition, it's safe on clinical grounds to say somebody has dementia because the likelihood that there's going to be another condition that explains it really is very low. And you are not going to get, it's not like there's some other potential cause that you'd say, well, this isn't dementia, and therefore we expect it just to get better, or there's some other treatment that we might use to fix it. So that's a really great question, and it's the crux of the challenge that we face with the disease. So another question there about, does brain cell regeneration occur among dementia patients despite cell death? That is another fantastic question. It is difficult to study the actual amount of sprouting of new neurons that goes on in human brains. You can do it more in mouse brains. And the question is really like, when you start dementia, does that mean that you're not regenerating neurons? Or does it mean that only those parts of the brain that are affected are not regenerating neurons, or that are having neurons die. And also the question, are the neurons actually dying more, or are they just not like keep staying alive as long or regenerating as long, or sprouting new connections? I don't know enough about the pathophysiology to say exactly. My general sense is that in Alzheimer's, the ratio of cell death to sprouting of new neurons is quite a bit different than in other people. And that even though this starts in certain parts of the brain, it then progresses to the entire brain. And I'll show you a picture in a little while of a brain of somebody with dementia, and you can see that their whole brain has seriously atrophied. So that is a great question. The other kind of interesting finding from recent work is that antidepressants probably work in some part due to sprouting of new neurons. Like you give an antidepressant to mice and you look at their brain slices, you can see that after a few weeks, they start to sprout new connections. And what we know about antidepressants in dementia is they really don't work. And one question is like, why? And my sense is that it may be related to this exact phenomenon that you brought up, that people with dementia are undergoing a brain change that stops them from the same type of remodeling or sprouting process. Great question. So question about the figure, I will track down where the figure came from, and we'll get that for you. Just email me, my email's at the end of the talk. And then predicting the onset of Alzheimer's before the symptoms of the subtype. So that's been a key challenge for all of us, and I think Emily's gonna talk some about that, is how do we know if somebody's got dementia before they show all the symptoms, or before there's a narrowing of the type, and it remains a big problem. As I'll talk about, there's risk in calling things too early and saying, oh, this looks pretty much like dementia, even if we don't have all the criteria. So it's not just like a level of uncertainty, because there is a significant risk that goes along with saying somebody has dementia. Briefly, the predictive models don't work that great. So the question you just brought up about the ethical prediction of the disease, I'll come back to this, but basically it's a very thorny issue, and there's a lot at stake. And your point that you don't want to know if you're predestined to have dementia is right on. And when they've surveyed people who got a diagnosis of early dementia, even when they were relatively confident, very many of them said, I'd rather not know. You know, if I'm headed that way, well, you know, I'll accept it, but please don't tell me, because it's going to ruin my life and my family's life. So back real quickly to I brought up antidepressants as a tangent, but that's a fascinating one. There have been many studies of antidepressants to prevent dementia. Unfortunately, the shorter answer is no, they don't prevent dementia reliably. Some epidemiologic studies suggest that certain types of antidepressants are associated with lower rates of dementia. But when you look at the data carefully, these are probably measuring some other association rather than causation. There's some interesting work that I happened to tag along with a group from Taiwan, where they looked at antidepressants when used for depression and antidepressants when used to treat migraine. And the bizarre thing was that the risk of dementia was opposite based on the reason for using the same drug. So if you used the same antidepressants to treat depression, you reduce the risk of dementia. If you use these same exact drugs at the same doses to treat migraine, you increase the risk of dementia. So just bizarre, and nobody really has cracked the nut of dementia prevention. And that's your other great question about over-the-counter supplements. Really no data about that. And we'll get to that in a minute when we talk about dementia prevention. Great questions. So this is my point about neurons dying. You can see very clearly when you have advanced dementia, your whole brain has shrunk. That's not just a sign of less water in there. It's actually lots and lots of neurons that have died. Unfortunately, it's not highly predictive enough that you could use this as a way to diagnose dementia. Please don't get the idea that you just do a brain scan and say, oh, you have dementia, because there are, in fact, a lot of people whose brains look about as bad as the one on the left who don't have dementia. And like some people with chronic alcoholism really have terrible looking brains on imaging, and yet they seem to function relatively well. And there are plenty of people we see who have what looks like a normal enough brain for their age who have significant dementia. But if you want to narrow in, I don't know if I can use a pointer, but basically it's the, well, anyways, the bit on the bottom of the top slide that looks like a little curly Q, that's the hippocampus, and those parts have really significantly shrunk or atrophied in the brain with dementia. The bottom line is it's about dead neurons and brain that's no longer there. So to go back to the problems that people have in Alzheimer's, there has to be a memory problem and other area of difficulty involving speech, carrying out coordinated motor activities. Oh, good, thank you. We can see the cursor. Recognizing things or carrying out higher level executive tasks like balancing a checkbook. And then there has to be functional problems. Just to come back to that again, please, there's one thing you remember from this talk. You have to have functional problems to have dementia. If you just have a memory concern or if you just flunk a memory test, then that's not dementia. You need to figure out what it is, but technically it is not dementia. And then it's a diagnosis of exclusion, so you rule out other causes. There are some other very important causes. You'll hear more about these next week and through the series. Delirium's a big one. Sleep apnea is a huge problem in older adults that often masquerades as dementia. Somebody's got untreated sleep apnea, their brain's not working well during the day. Sensory impairments are a really big deal in terms of ability to process information. And then PTSD can be a very big factor in cognitive difficulties. Emily, I don't know if she'll be talking about this next week, but she's developed some fantastic materials in intervention to help our older adults, especially veterans who have PTSD, who have cognitive problems. And in treating them, and when they realize that PTSD is really a core issue, they are able to make really big strides and oftentimes to bounce back from what looks like a serious cognitive problem. So there are other things to consider. Yeah, so a great question about progressive hearing loss. This one's complicated. I sat on a dissertation committee about sensory impairments and dementia. And frankly, I was kind of skeptical up front whether you would say that hearing loss or vision loss causes dementia, because it didn't make sense. But there is some compelling data that the PhD student had that really, they kind of went hand in hand. So it could be that your ears and your eyes are kind of extensions of your brain anyways. So as the brain cells die, you'd also expect cells in the visual cortex and in your inner ear to be perishing as well. So I wouldn't go so far to say that hearing loss causes dementia, but certainly that it's a major factor in communication, and also that it may be associated with cognitive problems. There has been some research showing that if you take people who are diagnosed with dementia and you test their hearing and take the ones who have significant hearing problems and then fix it, then and retest them, a lot of them no longer seem to meet criteria for dementia because their functioning improves and their scores improve. So it may be that that is a reversible factor, and which would make you say that it's not actually dementia, but rather just hearing difficulty is a cause of cognitive problems. Great question. So I want to talk quickly about what you see in Alzheimer's and then give you a caveat about not assuming too much. So it's a slow, steady decline. People usually don't have much insight. So when I ask patients, how's your memory? They'll say, oh, it's fine. I don't have any problems. Insight is often the first thing that goes. People usually come relatively late to medical attention. It's not like vomiting blood or having some other major medical problem that you rush in as soon as you notice it. It's usually 3 or so years into the challenges of memory difficulty that people present for care. Alzheimer's tends to be pretty stable. There's not a lot of up and down. And the overall course is about 8 to 10 years from the time of diagnosis until death. Usually people die of medical problems because they were older when they got the disease anyways. But if they're not treated, eventually Alzheimer's would be fatal because the whole brain is just not working. So here quickly are the stages of Alzheimer's. Mild Alzheimer's takes 2 to 3 years after diagnosis, so about 3 to 5 years into the disease. Mainly higher level tasks like remembering a lot of details or complex visual spatial processing. There may be difficulties with day-to-day functioning and decision making. To remind you, there have to be functional problems for a diagnosis. The best way to get at that is to ask someone who lives with the patient, are there things that you have to do for them that he or she did for themselves before? And if the answer is no, like if they say, he can still do everything he used to, then you want to question your diagnosis. But if the spouse says, yes, he used to do the checkbook, manage his medications and drive, and now I have to do all those things, that's much more suggestive. In moderate Alzheimer's, it's kind of what you'd expect with increased problems with functioning and carrying out more basic tasks like speech or activities that require multiple steps. Oftentimes in this stage, people will show more psychiatric symptoms. It's more around the lines of not making sense of the world. Like, my wallet was right here, now my wallet's gone. Somebody must have stolen my wallet. So it's different than psychosis as you might find in someone who has like schizophrenia, where it would be a bizarre delusion. This is more like somebody's just not processing the world and they're doing the best they can to make sense of it, which looks like paranoia. As you get on into later into the disease, people's ability to express themselves really suffers. A lot of word finding difficulties. This is the stage where people typically show more aggressive behaviors, in particular when they feel like they're threatened. So if you could see the world from their perspective, they're being attacked or something is wrong and they're defending themselves or trying to make it right. The not necessarily worsening there means that as people get worse and worse, it doesn't mean that they're going to get more and more agitated. In fact, frequently they just stop noticing there's a problem, and so they just spend their time more passively. So it's not like as you progress through Alzheimer's, you get more and more aggression. And then very late in the disease, you can see more motor symptoms. And eventually, if there are no other medical problems, people lose the ability to protect their airway and they would die of a pneumonia. But typically, it doesn't progress that far. But earlier in the disease, there are not typically these motor symptoms. Now, here's my warning. And it's from the Alzheimer's Association. I think it tells a lot. When you've seen one case Alzheimer's, you've seen one case. So there's really no way to predict what one individual is going to do. Just this morning, I was talking to a woman who's caregiving her husband who had dementia. And she had also taken care of his father who had dementia. And since they're blood relatives, she expected the son to be like the father, and said, I couldn't believe it. They're so different. You know, they got the disease about the same age, but one of them was pretty much like himself the whole time. The other one had a lot of personality changes. One of them had good language and the other one lost his language. So it's very difficult to predict really what's going to happen. And I discourage you from trying to put people in boxes. Instead, what you can assume is that there's a disease that takes about 10 years total, that involves various cognitive difficulties that tend to get worse over time without much waxing and waning, but it may not be any particular area that's a guaranteed problem. So I want to talk about genetics and then prevention. So early onset dementia before age 60 occurs less commonly, but it's much more likely to be genetic or inherited. So if somebody has a parent who got dementia in their 40s or 50s, they're at a higher risk. If their parent or first degree relatives got dementia later in life, like in their 70s, 80s, or 90s, their risk is not greatly increased. That's an important one for discussing with families who, when you're giving them a diagnosis, worry about their kids. There's ApoE4, apolipoprotein E4, is associated with higher risk of dementia, but it's certainly no guarantee. So it's not really that useful to know. And this is my very, very rough take, but my sense is that the cause of dementia, which we don't know, is probably an accumulation of some changes that happen on a random basis. And when you happen to line these changes up, they lead to a process that goes off on its own. And whatever changes they are tend to reach a peak, starting of a peak at around age 65. So it really is much more of a sporadic condition than are other forms of disease that have a genetic basis. So then you may ask, well, why do we have more dementia now? Like, why didn't Alzheimer in the 1910s find more patients? Because now you can go to a nursing home and can't turn around without hitting somebody with Alzheimer's. And the reason is basically that people live longer now. And because dementia is an age-associated condition, the rates will go up as people in the population are older. This trend, unfortunately, may not be continuing in the United States, given recent data, although the group of older people is probably aging at about the same rate, and the lower life expectancy in America is attributable to deaths of younger people. But in any case, it's clear that we live about 30 or more years than 30 years or more longer than people did 150 years ago, or even 100 years ago. So if you don't have that many people over age 70, you're just not going to have much dementia. And that figure down at the bottom and the one I showed you before clearly demonstrate that if you don't have many people over age 70, you're not going to have much dementia in the population. So you don't need to turn to some other explanation like aluminum pots or electrical discharges or some infectious exposure. In fact, the epidemiology is explained almost entirely by the age of the population. So the question before about prevention was great. This is 10 years old, but still pretty updated. I haven't come across anything that changes these findings. It was a full review done by the NIH where they looked at preventing Alzheimer's and cognitive declines. This is their unfortunate finding that there's really no evidence of anything to prevent cognitive decline or Alzheimer's. You know, it's frustrating. There are lots of studies that show associations between things like diet or activity or pills and lower rates of dementia. But when it comes to actual trials that see if something can prevent dementia, you don't have anything. That's the bottom line. So we have a point there about reluctance to test for dementia early on. How we'll know what the progression is. That's a really great question that has kind of public health relevance too, because if you're not identifying people early, how are you going to know what worked to prevent it or not? And I would say that you don't necessarily need to make a diagnosis of dementia, that if we're able to get a large enough group of people and track their cognitive and functional status over time and look at what their exposures are, then we could probably get a better sense of whether there are interventions that could improve their likelihood of getting dementia. They're also focusing in studies, especially in South America, on families that have a very high rate of dementia at an early age. The challenge there is that it may be biologically different than the sporadic dementia that I mentioned. So very, very tough issue to deal with, and I'm really glad you brought that up. I know that the talk after next is on preventative strategies, and you may get a slightly different story there, so I don't want to overstate this a ton, but my general sense is that we don't have any good known approaches for preventing dementia. The other question about progression, great question. I'm not dealing with treatments here, but basically the treatments that we have for dementia are for the symptoms of dementia. They do not change the long-term course. And if you go back to what we were talking about before about neurons dying, unfortunately, we just don't have drugs or supplements or lifestyle things that keep neurons alive once you start this process. I wish I knew exactly how that happened, but it really seems to be the case that once you get this decline and this type of neuron death, no matter what you throw in there, you're not going to salvage the neurons. There are plenty of small studies that make it look like you can salvage neurons, and if you watch cable TV, you'll see ads for Australian green mussel extract and the effects of coconut oil. And who knows, maybe those do work, but there's just no science around predictable ways that you can stop someone from getting dementia. And the place this really, I mean, the rubber hits the road is I don't know of any published, well-documented case of somebody who had dementia who bounced back. Like, there's sometimes people who get dementia and then they stabilize for a while and do okay, but you don't recover from dementia, especially when you're having significant cognitive problems and or you have signs of neurodegeneration that have happened. So maybe in the future we'll develop drugs or treatments that will regenerate neurons, but right now we're pretty darn far from that. So here's just an example of why I am reluctant to talk about why prevention would work great. So these two people, questionable politically, but very healthy, very smart, smart enough to be leaders, no real bad habits. They're thin, athletic, as you can see. Both of them got dementia and died from it. This guy, Claude Shannon, we wouldn't be here probably on a computer without Claude Shannon, because he invented information theory that we use. You can see he's very healthy looking, no bad habits whatsoever. He spent his time juggling and playing chess and riding a unicycle around. So everything you could have done to prevent dementia, he did. He got dementia in his early 70s and died from it. A lot of patients I see are extremely healthy through their lives. There's a guy who was a lifelong vegetarian, never drank or a drop or smoked a cigarette. He was a marathon runner into his 60s, and looked 20 years younger than he was. He got dementia. And I've got plenty of patients who are overweight, drink, smoke, have diabetes, many health conditions, who don't have dementia. So there are certainly correlations, but in terms of anything predictable that you could do in terms of your habits, the science is just not there, which is discouraging in one way, but I think it's also empowering in another, because it means that you didn't cause dementia for yourself. When somebody gets dementia, the last thing you want to do is tell them, oh, your blood pressure was bad and you ate a lot of cholesterol, because that doesn't help. So it's not the case that lifestyle is not associated with dementia, but that after the fact, you really shouldn't be attributing lifestyle issues as the cause of dementia. Lifestyle factors are much more reliably the cause of things like diabetes or blood hypertension or cholesterol problems. So great question about autoimmune onset. There has been a lot of work in that maybe that's the starting point for dementia. I honestly don't know the research well enough to say whether that makes sense as a plausible explanation, but it very well may be that there is some kind of autoimmune process that goes on. It's a little harder to explain because I showed worldwide graphs before, and the rates are relatively similar, and you'd expect if there was some kind of variation like that it would show up differently across different populations. But it could be retirement and dementia. Yeah, certainly there has been work about life change, and my general sense is that retirement isn't going to cause your brain cells to die, but it can suddenly expose a lot of issues that weren't there before. So a related issue that comes up with spouses is like, if you keep your brain active, by doing Sudoku puzzles, will that stop you from getting dementia? They'll want the person with an early diagnosis to do brain puzzles. And unfortunately, that's not the case. Use it or lose it applies to some things, but it really doesn't apply to dementia because you've got brain cells that are dying. It's not, they didn't start dying because you weren't using them. So that great question about the Bredesen, the end of Alzheimer's. I've looked at that stuff, and there's anecdotes, but as I mentioned, in the mainstream scientific literature, at least, there are just almost no reliable reports of people who had a clearly diagnosed dementia making changes that then brought them back. And I've had patients who became very interested in that approach, who made drastic lifestyle changes. I didn't discourage them. I told them, you try what you want. I'm not going to say it won't work. And at least in my experience, none of them had any significant effect after some initial sense that it was improving. So great questions. I'm really glad you brought that up. And I don't want you to get the sense that I believe I understand this stuff or that dementia can't be cured. or that I know all the reasons. But I do think that the data is pretty compelling, that once your brain cells have died, you're not going to get them back, despite lifestyle or dietary interventions. Yeah, the great point about learning languages. There's some really fascinating work, even to suggest that people who have a higher pre-morbid level of cognitive ability and higher educational attainment have a faster drop once they get dementia. So like 3 years into the disease, somebody on average who has a higher educational level is going to look worse than somebody who had a lower educational level. And it's not really that they probably are worse, it's just that they showed up a little bit later and they were able to have more workarounds early in the disease. But unfortunately, all this hard work we're doing now at education would not prevent us from having problems if our neurons started dying. All right, taken a little longer than I expected. I wanted to go through real quickly the other subtypes and then touch on the initial theme about the whole person. So vascular dementia is a funny one, because it really mimics Alzheimer's, which is funny because it's a different process in the brain. Basically, it's small blood vessels. It's not strokes. If you have a stroke, part of your brain dies. Potentially, you can have a workaround, but it's not slowly worsening. Whereas vascular dementia is the small blood vessels, and at some point, you start this worsening process that just gets worse and worse over time. There are known risk factors for vascular dementia, but as with Alzheimer's, when you really do when you correct the vascular risk factors, the Alzheimer or the vascular dementia does not go away. It keeps getting worse. So very, very strange that the same thing or you'd have a differential effect from what causes it from what continues it. And that's why that question before about preventing worsening was so great. So let me show you real quickly slides of vascular dementia. The ones on the slide on the left top is a big stroke, and the ones with the arrows are small vascular changes. And the strange thing here is that you could have worse cognition with the little changes than with the big change, because the brain on the upper left is still remodeling, and even though parts of it died, the other parts are still okay. So I want to come back to the question. So first on the vascular one, so what happens to the blood vessels? So this is what's known as microvascular angiopathy, which is where the small blood vessels develop basically amyloid changes. So the small blood vessels close down. And when people have looked at it more carefully, it really does overlap considerably with the amyloid changes in dementia. So there is some thought that really amyloid is the crux of or critical breakpoint in both vascular and Alzheimer's dementia, and that you're just seeing different manifestations of them. And how it differs from TIA is that a TIA is a temporary event, and then the blood flow is restored. So in vascular dementia, it's a more global problem where lots of the small vessels eventually close down, and those parts of the brain eventually die. Great question. I want to come back to that question about vascular cognitive reserve. So that's a super question, and as I pointed out, I think what cognitive reserve gets you is early on, you're able to do better or to essentially fake it better. But after you get to a certain point, it doesn't matter. No matter how much cognitive reserve you have, if you've had enough brain cells dying, you're not going to be able to function at a high level. And that would explain the reason why people who have higher cognitive reserve tend to drop faster. So it's different than building reserve then protects you so that people who have different levels of reserve are declining at different rates. Instead, when you look at this literature, it suggests that the higher reserve people tend to drop faster. That's a really great question. And then untreated hearing loss associated with dementia. Yeah, so we'd mentioned that a little bit before. The basic issue about that is that it's probably a similar process in hearing and the brain, and that it doesn't necessarily make sense to say that hearing loss would cause dementia. So the question about small strokes. Yeah, so this is exactly what I was trying to get at with the difference between a stroke and dementia. So there are certain parts of the brain that if you have a stroke in them, you'll have specific cognitive deficits that persist, but most of those don't look anything like dementia, which is more of a global, general worsening problem. And if you've treated people with strokes, what you know is either they're going to have the same level of functioning over time, or a lot of times they improve. So the neurologists give you a year until they say that you're at a new baseline. So if somebody has a stroke, then they're going to have to deal with the consequences, but that's different than a progressive neurodegenerative condition. So that's a great question. And in fact, when I learned about vascular dementia, it was considered to be like a stair-step progression of little strokes. And I don't think that model really accounts for what happens, because it's such a different thing than stroke. Great question. All right, I'm gonna skip over the none. Basically, this shows that there's a big overlap between Alzheimer's and vascular disease, because I do want to get to vascular or Lewy body dementia. So Lewy body disease is one that overlaps considerably with Parkinson's disease. They show very similar findings. The little inclusions there, the pink thing and that thing are Lewy bodies. This one is less common. It often occurs with Alzheimer's, and it shows the motor symptoms that go into Parkinson's. So stooped posture, shuffling gait, and a masked facial appearance, which is like you're not showing emotion. The other finding that you get is visual hallucinations. And oddly, they're usually not like freaky visual hallucinations. They're more just like, oh, I see little things up there, little people in the carpet. If somebody's got visual hallucinations, make sure you consider Lewy body disease. It tends to have much more waxing and waning day to day, and you may have these other symptoms before you have memory problems. The reason for identifying this one is mainly that you want to avoid antipsychotic medications, which can make it worse. All right, I want to make sure we talk about frontotemporal real fast. So this is a much rarer condition. It involves specific atrophy to the front parts of the brain, and it's the part of the brain that controls your personality and your ability to control yourself in social settings and to carry out complex tasks. So people usually show disinhibition or apathy early on, very poorly regulated social behavior, even though their memory functions fine, and then later on they will show more memory problems. So on the right side of the slide, you can see the frontal changes that are going on in the brain. It's atrophied considerably, and then eventually that passes around to the back. So these, quickly on the reversible dementia, these are all medical problems that cause cognitive difficulties, but they are all things that can be identified and sometimes fixed. In the old days, it would be that you may not identify one of these and you would call somebody demented, but nowadays we identify them very quickly due to lab tests, and so they really shouldn't be called dementia. Instead, they should be called cognitive impairment due to medical problems. So I think I'm going to stop there and go back to the question about a couple of questions that came in. One about no cures, but a lot of research happening. Yeah, so there is exciting research. It's focused on a variety of agents. There are challenges to treatment early on because it requires you to identify people and then also to apply a treatment that may have risks. So it's a challenging area, but you know, hopefully in the future we will have better ways of understanding what happens early in the disease and then intervening when it's early enough to make a difference. So visual hallucinations, great question about visual hallucinations. Yeah, the visual hallucinations, at least in the population that we see, are almost exclusively either Lewy body dementia or Charles Bonnet syndrome, which is loss of vision, especially in macular degeneration when people get hallucinations. But at least in psychiatry, we don't see people who have well-formed visual hallucinations in other forms of psychiatric disease. And people with other forms of dementia may have visual hallucinations, but they tend to be more kind of hazy or misinterpretation rather than something well-formed. So if somebody has well-formed visual hallucinations, you really want to make sure that you do a workup for Lewy body. I can't think of any patient I've seen in 12 years who had visual hallucinations of this type, who didn't have Charles Bonnet syndrome, who did not end up having Lewy body dementia with symptoms of Parkinsonism. So that is a great question, and you know, please email me if you have more information about that, because I would love to learn more. So Barb, I think, are we out of time? Are we only supposed to go till 20 after?
We are, but if you've got time, we could probably go until 5:30. It's up to you.
Okay, I'll keep going very briefly. Just
okay.
that you can see it. You'll all have the slides, but the key to working this up is to get a good history. Make sure there's no delirium. There's some tests that you can do, but those are not purely diagnostic. It's really based on the history. Screening for dementia is a mess because our tests are not perfect. And if you do the math, you find that you end up misdiagnosing a lot of people as having dementia, and that has significant problems for them. So be careful before you recommend screening. And back to my very original theme, the most important thing is that you understand what the person's life experience is like, and don't make assumptions about what's hard for them and for their caregiver. And really, it's the social and personal support that make a difference rather than the medical management. And then if you have somebody who's agitated, consider the behavioral aspect before using medications which have a considerable risk. So I apologize for going long, but I really appreciate the great questions. And here is my contact information. The email is the better one. That's not my phone number anymore. And I would love to hear from you. And I hope that we got to all the key questions during this. And if not, just let me know. And as I mentioned very initially, this is just the kind of sneak preview of the other content that you're going to be getting through the series. And I hope that you pick up a lot from those. I know you will.
Thank you so much, Dr. Thielke. What an outstanding presentation and a great launch to the winter series. Happy New Year, everyone, and we will see you next Tuesday.
Great, thanks.